Hello everyone and welcome to our session today, Introduction to Domestic Violence and the Implications for Nursing Practice. Our presenter is Dr. Joan Garvan, Director of Maternal Health and Wellbeing. Joan's research is in sociology and gender. In December 2010, Joan was awarded a doctorate from the Australian National University and her thesis was titled Maternal Ambivalence in Contemporary Australia, Navigating Equity in Care. Since completing her studies, Joan launched an internet site which offers online professional development courses. She has 4 years' experience working with the Australian National University as an online moderator for a unit on gender and development. Joan has completed a semester with the Australian Catholic University as a lecturer on Introduction to Sociology. She has presented papers at dozens of conferences, including the Australian Institute for Family Studies, the Australian Sociology Association, and the Association for Research on Mothering at Queensland University, York University in Toronto, and in New York. I need to tell you, Joan has a head cold, so she will need to take a drink every now and then throughout this presentation. But thank you, Joan, for your willingness to continue your participation in this webinar. Joan, welcome to the microphone.
Oh, thank you, Sue. And I hope that my voice comes over okay, but I'm feeling much better. So it's been an interesting process doing the research for this paper, and I'm really glad that I've been able to do it. It's given me quite a reasonable background in the area now. The vast majority of dangerous, abusive, and violent behaviour that occurs in the privacy of people's homes and is committed by men against women. The most recent information on violence in Australia comes from the ABS. And I'll just go down to the next one. There we go. Oops. Here we go, sorry. One in 5 women have experienced sexual violence. 1 in 6 women had experienced physical or sexual violence from a current or former partner. This is from the ABS 2012. 1 in 4 women had experienced emotional abuse by a current or former partner, and 1 in 3 women had experienced physical violence. Aboriginal women are 45 times more likely to experience domestic violence than a white woman. And these statistics, I think, probably are well known, but amongst the documents that are attached to this presentation is one with key indicators, and I think you'll find that very helpful. It's quite a good overview of these key statistics. With Aboriginal women, I'll talk a little bit here, although the paper goes in more generally into other things. I think that Indigenous health would deserve a PowerPoint all of its own, or a webinar all of its own. One of the things that surprised me with the Aboriginal experience of violence was that the patterns were passed on from parents to their children, and it takes the police up to 2 years to respond to cases of domestic violence, which I found very surprising. The Creative Spirits site that's listed in the associated bibliography that comes at the end of the text document that you will receive sets out ways to respond, which emphasises community engagement and empowerment through employing Aboriginal staff and working in partnership with the Aboriginal community. And there's another site that's listed on the bibliography as well that I think you'll find useful in terms of information on Indigenous health and violence. In 2010, the Council for Australian Governments released the first report from a 12-year strategy to reduce violence against women and their children. And it's interesting with all the talk about domestic violence that's been in the media over the last months over, with Rosie Batty, I haven't really heard mention of this report a lot. I'd be interesting to know about other people in that regard. But because the expectations and the experience of women in Australia has changed dramatically over the course of the 20th century, this session will firstly outline issues and campaigns that were taken up by the first and second waves of the women's movement, so as to reflect on these findings within the historical context. I'll then set out the key points for nurses from this national plan to reduce violence, and draw out issues from the associated research that includes strategies. And I'll also provide, I also provide links to resources and to programs. There's quite a lot there. My perspective is informed by a social determinants of health perspective, which is promoted by the Australian Women's Health Network and defined by the World Health Organization as the conditions in which people are born, grow, work, live and age, and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies and political systems. So very wide brief, that is. So the first part I'll just go on, just give a brief overview of some of the changes over the 20th century, this historical context. Violence in the home has been an issue of concern that was brought to the fore in Australia by both the first and second waves of the women's movement. Campaigns during the early 20th century to gain the vote were accompanied by an emphasis on improved services and payments for women as their role as mother. Gendered roles, which were commonly practiced during the early 20th century, were cemented through a marriage bar in post-World War II, requiring women to leave their job once they were married. There was a dividing policy in practice between the private family realm and the public, legal and structural arena that effectively ascribed women second-class citizenship. Women's rights were dependent on the goodwill of their husbands, and the marriage bar, you can find more about that if you wanted to online. There's been a bit of an overview that's available online. That was lifted in 1965 and ushered in the whole, women in the workforce that happened after that. Married Women's Property Acts were passed across Australia by the early 20th century. They were, however, legally nullified within marriage by the male breadwinner model of the family, which advantaged the person who made the primary financial contribution. The 1907 Harvester case depicts this practice through the breadwinner wage fixing model that granted a minimum family wage for men and not women, even if they worked in the same job and were sole parents. This breadwinner wage was set in accordance with the requirements for a dependent wife and 2 children. There were landmark cases in the 50s and 60s whereby, in the case of marriage breakdown and disputed property, the decision was made in accordance with the financial contribution and did not take into account the contribution made by the primary caregiver. This practice was overturned by the 1975 Family Law Act that recognised both financial and non-financial contributions and thus accounted for the care of children. This change in law was accompanied by an equal wage case, 1972, and a multitude of advances made by the second wave women's movement, and provides a basis from which couples could aspire to equal or egalitarian family forms. There's an emerging body of research demonstrating that both contemporary men and women aspire to an equal or egalitarian family form, and yet after the birth of an infant, trends toward gendered roles are a consequence of a failed institutional response to cultural change. Advances for women through law, education and employment have reached a new high water mark. in that wage fixing is currently set along the lines of an independent worker model. This disadvantages the primary caregiver, who is in turn dependent on the goodwill of the earner to share their wages and to share the care. This is labelled in the relevant literature as the motherhood penalty, and that's well documented. Institutional practices such as these frame the experience of men and women within families. It's well and good to aspire to gender equity before the birth of a child. However, once couples are responsible for care, they are required to negotiate the needs of their infants and children, as well as disability or illness, and at some point, the needs of their aged parents. These are activities that have been relegated to the family, and through this notion of the breadwinner family, the breadwinner and the carer, that is kind of imbued in our system so deeply that we really haven't come to terms with it. But they're now being increasingly commercialised through child aged care and the incoming National Disability Insurance Scheme. The ability of couples to negotiate, however, is dependent on access to finance, access to extended family support, and importantly, their ability to communicate, to be flexible, and what has been recognised in the literature as the disposition of the male gatekeeper. Underlying my argument is the proposition that the relegation of care for infants and children, the aged and disabled, to the family has meant that the primary breadwinner has an advantage over the primary caregiver, whether they be male or female. The primary breadwinner has maintained their workplace attachment, and therefore, if there is a breakdown to the family unit, their financial position is more secure. This is referenced in the literature as the feminisation of poverty, and again, a lot of literature backing that up. That often accompanies family breakdown. I'm suggesting this is an important contributing factor to an increase in the incidence of domestic violence during pregnancy and in the early years after the birth of an infant. There is talk of a dual earner, dual carer model of wage fixing in the literature. This hasn't, and it's kind of getting into discussions at more a policy level. Occasionally I'll come across reference to it, which is interesting. But I'm proposing that couples are often caught between a rock and a hard place after the birth. There are increasing financial and social pressures on them in terms of life choices and expectations, but also in terms of their approach to being a parent. Couples with family support and or the finances to be able to outsource to nannies and cleaners may find ways to make it work, but for many the tensions are great. And again, another webinar I could do in that line is there's a multitude of literature on what it means to be a mother today, and that's kind of an area of an expertise that I have. This whole thing about good mothers and bad mothers and shaming of women when they go to work, or shaming if they stay at home. It's that they can't win, and it's just adding a whole lot more pressure on women to perform in prescribed ways, which obviously would affect their health, and it wouldn't, create a whole lot of guilt within families. But I thought this might be a good opportunity here, Sue, to if anyone wanted to make any comments or...
If you would like to make a comment on Joan's discussion thus far, you can type your comment, if you're attending the session live, into the question panel and hit send, and that will come through to Joan. Joan, the statistics that you cite at the beginning of the discussion, 1 in 3 women experience physical violence.
Yes.
And 45% or 45 times more likely for Aboriginal women to experience violence.
Yeah.
They're amazing statistics.
It's hard to comprehend, isn't it?
It is. It's exceptionally hard to comprehend that. And I suppose that was the intent behind the webinar. Like as nurses, as midwives, as child health nurses, 50% of our client base are female. So with those statistics in mind, the reality is we are going to come across women who are experiencing domestic violence. It may not be the prime reason why we're working with them, but it may be an issue that arises during our discussion with them. And therefore it's vital for us to know the strategies and our responsibilities under those guidelines.
Yeah, well, that's where I'm hoping that this will be a useful webinar, because I've linked a whole lot of resources and programs, particularly online training. There's a couple of sources for online training. If people didn't know about them, I think they'd find them very useful.
And the term feminisation of poverty is a very real one.
It is, definitely.
In my own, not my own personal experience, but my experience in working with colleagues is that when there is a marriage breakdown, the difficulty then of, splitting the resources that jointly have been worked together and then having to live off what usually in the experience of my colleagues has been a part-time wage, but, continue to provide that level of monetary support to children and those sorts of things is exceptionally difficult.
And some of the regulations are really problematic, where, women can be caught with children and they're not getting the money from their partner. Their partners can hide the money,
They just don't pay.
They don't pay. They organise their money so they're not making any income. I know of cases like that, but, I'm sure there are men who do the right thing, but unfortunately there's a lot who don't.
No, well, certainly from the experience of my colleagues, it would appear that there are a large proportion of partners out there who don't financially support the person who ended up, with the dependent children.
And a frightening thing, which I hate to even verbalise it because it's so awful, and we see it every time we see Rosie Batty. It's a way of punishing the mother,
Oh, horrendous.
And it happens. It happens. And I think often the media aren't reporting it because they don't want to cause, they don't want to press any more people into it. But I think that's happening more than we know, to be honest. There are
certainly
celebrity case, there are cases that have, there's been reported widely, but yeah, it's one of those things that I'm afraid to look behind.
If you scratch the surface, you just don't know what you're going to find.
Yeah.
All right, we might continue.
Yes, okay. So now this national plan to reduce violence against women, that at this point I'll outline relevant aspects of this national plan while noting a particular focus on the part played by health professionals, in particular the early years practitioners who work with women and their families, and these are really frontline workers. The 12-year framework includes 4 3-year plans: Building Stronger Foundations, which finished a couple of years ago, Moving Ahead, which we must be in this phase now, Promising Results, and then Turning the Corner, let's hope. The first action plan focused on 6 national outcomes, and those related to health practitioners. Just go down. Relationships are respectful, communities safe and free from violence, Indigenous communities are strengthened, and services meet the needs of women and their children experiencing violence. They're very broad, but especially the relationships are respectful, I think, those early years services, and I'll talk more about that later. But I think there could be a really helpful part to play there. Communities safe and free from violence. Well, yeah, that's a very broad one. So it's more, I think, training and contribution that would help there. The strategies across the Commonwealth, state and territories are, and now there's a list of things that, that I've included here, to promote community involvement, health and education organisations to take a role to prevent violence. Interesting, that was in the report. So health and education practitioners are mentioned there. To support men to take a leading role, that can happen again, that can be integrated in the services. To challenge discrimination and gender stereotyping. This is, interesting that these things are listed in the report, and it'd be really interesting in terms of what practitioners think, how that translates into their everyday work. To focus on a primary prevention framework, dealing with underlying causes through promoting positive attitudes and beliefs, reflecting on social norms. Advancing gender equality by challenging narrow gender roles and stereotypes, building equality and respect between men and women. Promote respectful relationships and positive parenting. Promote positive male attitudes and behaviour. Strengthen Indigenous communities. Foster leadership for Indigenous women within communities and the wider society. Build community capacity at a local level, improve access to appropriate services. So I know they are very broad, and it'd be really an exercise in itself to then draw out from them how the implications are for health practitioners. And that'd be a job in itself, I think. I haven't done that here. Now, in this, from here on, for a bit, I'm going to refer to highlight some sites and programs that are available online in response to this. And again, in the text document, there's a lot more links there and a lot more information and reports. But here in the webinar, I've just brought out a couple of them. And again, in the text document, I show you how to access these links if you don't know. So I won't go more on about that now, but this is how the text document will be laid out, the name of the report and the site to go to. And in the text document, I've given a couple of different options if the link doesn't work for you. So the first that I'm going to reference here is the Federal Government Department of Health Clinical Practice Guidelines for Antenatal Care on Domestic Violence. Very useful. I think that must be very useful, and it'd be interesting to know from practitioners how many people actually already knew about that, if that was unnecessarily passed on to you. The next one is this New South Wales Department of Health Centre Against Violence, which is a really excellent site. They provide online courses and resources, and that's a link to the courses. So again, very, very useful. Lifeline provide domestic violence response training called D-Alert, and you can select an option for health and allied health workers. And there's the link. The Victorian Family Violence Risk Assessment and Risk Management Handbook for Maternal and Child Health Nurses was developed by the Swinburne, I think it's University, Handbook for Maternal and Child Health Nurses, Risk Assessment, very, very useful document there. South Australia Family Safety Framework, a practice manual, another useful document available to download online. Now, the Australian National Research Organisation for Women's Safety or otherwise known as ANROs, have set up a practitioner engagement group, which they call PEG. And you can see a list of these experts here. This provides links to expert advisors who can assist practitioners translate research into practice. Again, very, very useful resource. And also ANROs have a homepage with links to services across Australia, resources and more. So another link you might find very useful. But I just thought that might be another time. It's just on 11:30. I'll go on to highlight some of the some key points that came out of the research that I brought together. But I wondered if this might be another time to just have another little chat.
Certainly, Joan, a lot of those resources appear quite new, like just identified in 2015, which is great. Yeah. So the recognition of the problem is there.
Yes, it is.
It's about getting that information out to practice.
Exactly, that's right. It's great to see that, there are some really good things there. So the thing would be for practitioners to know about them and to have the opportunity to look at them, and to absorb them. I mean, I'm just showing the links there, but to each of those reports, they're probably multiple pages and a lot of information to absorb.
And certainly the hope from this webinar is that those that are listening to the webinar seek further information and then take it back to their workplace and cross-reference your own organisation's response.
Yeah, excellent.
Like nothing changes unless we make it change. And we do have a responsibility within our community as nurses to, certainly obviously do no harm, but support the community in health-related issues. And domestic violence is a health-related issue.
Yes.
And we need consistency in our response. Joan and I were talking this morning before we went on with the webinar that both our experiences would suggest that it's dependent on the individual health worker, whether that be a nurse, a medical officer or whoever, that the individual comes in contact with as to how successful the outcome of that relationship's going to be, because we all bring our own knowledge to the relationship we have with our clients. But if you have got the knowledge and you understand the resources and you understand the implications of this issue on so many lives, then you're in a prime spot to be able to make a difference to the individual woman, her family and the greater community. And that's the hope of providing the information to you.
One of the problems I think often practitioners might find themselves in is that, again, they can be caught in that rock and a hard place because they can't speak out. They are the frontline workers. Now, I feel no doubt about that, but often they're stretched. Funding's always being cut back. They don't have much time. They're trying to deal with, a multitude of concerns. And here's another one.
Yeah. So what do we do what do we do in that situation?
Well, I think personally I'd like to, I think it'd be really valuable for nurses in, groups, representative bodies of nurses to come out and speak out and say, well, look, yes, we can see this is an important social issue, but if we are the frontline workers, we need funding, we need to have training, we need to have, resources to be able to deal with these things if we're going to be expected to. And I'd certainly be a person. I think there'd be a lot of support from the community for any groups who came out, along those lines. I very much support them.
Because the other, and as you rightfully say, there you need knowledge, but then you also need to be able to have the resources available to you to be able to assist.
I mean, the awful thing now, and, you know, I can do this because I'm an independent researcher and it doesn't, you know, I don't have to, I'm not responsible to anyone. But unfortunately, I think that all the rhetoric about domestic violence is rhetoric because at the same time they're closing all these refuges. I don't know how many, it might be in the hundreds, but it's certainly in the dozens have been closed. While at the same time they're making all these noises about dealing with domestic violence. There's a mismatch there.
And if you read the literature, the reason that women go back to an abusive situation is that they may take the children and decide to go, but there's nowhere to go to.
No.
Because there's no bed available for them. They're turned away. So the only way to put a roof back over those children's head is to go back to the abuser.
Yeah.
Who promises never to do it again, blah, 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 blah.
Exactly, that's right, yeah. And the critical thing here is children. You know, one of the things I reference later from the research is that a large percentage of, in a high proportion of cases where there is violence, there are children under 5. So, you know, there are children.
And that goes back to your discussion, Joan, of one of the major stresses or one of the major changes in role and relationship is after the birth of the first child.
Yes, that's right. Yeah.
Yeah. Again, as you identified too, Rosie Batty, you know, continues with some sense of exasperation, I think, when I heard her interviewed the other day. You know, we know the problem exists. And we, as you rightfully say, the rhetoric's there identifying the problem, but the resource allocation to actually constructively manage doesn't actually meet the rhetoric.
Not at all. It's very, I mean, really, it is taking away. They're not just not putting more resources in, they're taking away resources at the same time. It's certainly a mismatch, which is weird.
Certainly. Yes, certainly. Sorry, back to you, back to your presentation.
Okay. Well, so I thought with the research, the first one that I would reference here, which again is included amongst the documents provided with the text, is this report I did in 2002 now, but it was called A Point of Vulnerability, Links Between Domestic Violence and Mothering. In this I set out issues and cited relevant programs and research. I referenced an Australian violence prevention specialist, Liz Mulder, who advocated health promotion as a preventative strategy. Ruth Setti-Purda also emphasised a need for significant changes in attitudes towards partnership in marriage, responsibility for childcare and support networks to take the place of the extended family in relieving the stress of childcare and guarding against the development of chronic abuse. And again, I'm sure there's an important overlink here with the whole thing about mothering, is that, you know, women feel so under assault, I think, these days when they become mothers. There's so many expectations, and then if they're in an abusive relationship and they're being hammered down emotionally and things, it's pretty hard to fight back. Among the strategies suggested to prevent further violence, Setti-Purda referenced the development of a national relationships skills parenting program in a range of culturally appropriate forms to teach techniques of conflict resolution and stress management and to raise awareness of basic human rights within families. This emphasis was reinforced by Kim Halford, who recommended the development of a skills-based relationship education materials and programs to prepare couples for the variety of life transitions, including the transition to parenthood. And again, I'll come back to that later on when I'm talking about the outcomes from the research. So it's been interesting bringing together the research. I've amongst these materials, I'm drawing out some key points here. You'll find in the bibliography at the end of the text document the references, so you can find the actual studies, which if there's anything particular you wanted to follow up, you'd be able to. And I show in also how you might find them if you have difficulties. And I don't mind anyone contacting me by email as well. I've got my email address there on the front of the presentation. And Sue might pass it on to you, because I've got copies of all these and I can easily send them out if anyone wants copies of all the reports that I have documented, because I've read through them. So much of the research that I draw from is Australian, and where it isn't, I draw out how the findings might be useful in the Australian context. The first is an outline. Online resource, and that's in the bibliography on Indigenous Aboriginal experience of domestic violence in Australia. It's listed under Creative Spirits. This provides an overview of the incidence of violence and emphasises the importance of empowerment, partnership and community involvement with solutions. Another important resource in this regard, and it's listed, is the Australian Indigenous Health Info Net, which provides access to information, resources and more. The paper by Carol Freudmeier draws attention to high levels of domestic violence and sexual assault for women with disabilities. This was in 2011, and it's increasingly been drawn attention to. Women and girls with disabilities have considerably fewer pathways to safety and are less likely to report. Yet programs and services either do not exist or are extremely limited. Lisa Hooker drew attention to a lack of research on DV screening in the well child setting, and the study by Spargo highlights the fact that much abuse remains hidden and that effective efforts are required to make it possible for women to talk about their experiences and to seek help. Rebecca O'Reilly in 2007 found a paucity of literature on domestic violence against women throughout the childbearing years. But furthermore, she concluded that the incidence is poorly addressed by healthcare professionals. Tamara Power found that many women privilege their mothering role over other areas of their lives, and for ill women, it can be difficult to relinquish what they see as their maternal responsibility. Mothering while ill is difficult, or, dealing with abuse. And women facing illness or abuse may need encouragement to accept help. Nurses are in an excellent position to encourage women to identify and draw upon sources of support. The paper by Marion Tower found that the experience of women who seek help from health and welfare professionals in response to domestic violence tends to be negative. This was 2012. The authors argued that there is a disconnect between women's experience of violence and how nurses construct their needs and deliver care. I think this is a particularly good study because you can go into it in more depth through the paper. Obviously, I'm just drawing out key points from it, but that might be of particular interest, particularly in light of earlier evidence of a lack of disclosure. This paper provides for a way of engaging with mothers' stories and thus breaking down these barriers. That is, if you have the time and space in your work routines. The authors emphasise the importance of adopting a flexible and open-minded response to women affected by domestic violence. Simon Lapierre argues, and remember these are all Australian studies as well. Simon Lapierre argues that limited attention has been paid to the issue of mothering in the context of domestic violence, and that dominant discourse in this area has been characterised by a deficit model. That was in 2008. He concluded there is a need for less blame and more support for women with children, a topic I'll go back to later. But further to this, Anne Mann identified a trend of what she called maternal alienation that can be used by violent men within their families so as to alienate children from their mother. Women can become isolated from sources of support, and these men become skilled at convincing her family, the neighbours, the children's school, any professionals involved with the family that she is mad or bad. People and services involved with the mothers and or children can make a positive difference in this regard if they support the mother to help her rebuild her relationships with her children. This enables her to support and protect her children in the future, as well as helping her overcome the effects of violence and abuse. The latest research points out the good practice for better child protection should be built on supporting the mother, not blaming or punishing. And I know Anne Morris used to do workshops along these lines, and you'll find if you do Anne Morris maternal alienation on Google, you'll find a paper by her, and I'm pretty sure you'll be able to find access to her if you wanted to follow up. Now, there were 2 international studies that may provide useful indicators. The first is from Finland and the second from Canada. In the first, Marita Husa set out to explore professional processes for making sense of violence intervention. She found a tendency by healthcare professionals to arrive at sense-making practices where it's possible to focus on fixing the injuries and bypassing the issue of violence as the cause of symptoms and injuries. The results indicate that developing successful practices both in identifying survivors of domestic violence and in preventing further victimisation requires a broad understanding of the effects of DV and the challenges to healthcare professionals in dealing with it. There's a need for new perspectives to create an adequate response both for victims and for professionals that includes strong support at the organisational level. The second Canadian study by Joni Ledger found that programs that delivered social support by peers to postpartum depression to be promising. And again, I thought this one would be useful because the same model could be used in support of women and family, women who are suffering with violence in the family. Ledger found that interventions should be targeted and take into consideration the age of the mother, any cultural linguistic differences, the mother's circumstances and her needs. All volunteers should receive training before they provide support and screen for their ability to commit time. Although the results were mixed, they provided insights into how peer support volunteers can be an innovative part of team approach to intervention. Yeah, the peer support, I think, can be very, very useful, and I certainly would like to see something develop along those lines. Following on from the peer support, Lucy Patton, and this is an Australian study, found that the success of intensive home visiting programs were dependent on the relationship between the home visitor and the mother. The role of a trusting relationship between nurse and participants that included shared decision-making was central to program engagement. And that was 2013, that study. A clear distinction was made by the mother in that they were engaging in a relationship and not a program, which is interesting. And I included this one here because I think it's true that there are industrial issues that come into this as well. The current Victorian Royal Commission into Family Violence have uploaded submissions which provide for insight and direction. One I'll highlight was made by the La Trobe Violence Against Women Network. The report draws attention to the significant role of alcohol in domestic violence. Alcohol is a factor in 50% of cases of partner violence and 73% of cases of assault. Households with violence are significantly more likely to have children, especially children under 5. The report draws attention to the lack of research on DV and in particular within diverse family forms according to ethnicity, disability and sexual orientation. They found good evidence for peer support programs that included mentors, both professional and non-professional. They argued that the nurse home visitor is an important touchstone. There is, however, a lack of training, lack of knowledge, of support, discomfort for health workers, issues with language and cultural difference. There were time constraints and issues with the presence of the partner who may be a perpetrator. They argued a need for improved maternal and child health services for vulnerable women and drew attention to the Vic Health Respect, Responsibility and Equality program that you'll find amongst the links. Lastly, I'll draw your attention to a substantive 5-year study that was conducted by the University of Western Sydney, and that's this one, and produced the report, National Framework for Universal Child and Family Health Services. Nurses and midwives provide a key role in providing universal maternal and child and family health services. However, the Australian Federation of States and Territories has resulted in policy frameworks that differ across jurisdictions and services that are fragmented across disciplines and sectors. This report came out in 2011. So even now, it's 3 or 4 years old, and I can't see any movement along those lines. The findings indicated that current policies were in line with international research and policy directions, emphasising prevention and early intervention, continuity of care, collaboration and integrated services. The court concluded that the congruence of policies suggests the right time is right to consider the introduction of a national approach to universal maternal and child health services. And I think in terms of this whole approach to domestic violence and maternal and child health nurses being frontline workers, even more ammunition along those lines, that if there was a national approach that included promoting some of those key points that I referenced earlier, and I'll just go back to some of the things that were listed in the Building Stronger Families. Primary prevention framework, advancing gender equality, promoting respectful relationships and positive parenting. There's a lot of key indicators there that are written into these papers that could all be integrated within those early years services, so particularly to help families, manage their relationships, manage their stresses, manage their communication, strengthen their relationship. Unfortunately, I think these early years services have been historically about the child, but my whole perspective on this is that we are in a period of change. Families are dealing with a whole lot of complex issues and trying to work as a unit and in different ways to how their parents did. And I think they need the skills to deal with all these competing factors that are, especially, when they've got young children in the house, and where to turn when things go wrong. They know where to turn and find support. Yeah, support for young families, it's across the research on postpartum depression, the need for family support, and yet the services are very, very patchy across Australia. It depends on where you live. If you're lucky enough to have good services in your local area, good on you, but it would be fabulous to have good quality early years services across Australia, something to aim for, and a note to finish on.
That's a great note to finish on, Joan. Because yes, if you happen to work in an area where they have exceptional child health and domestic violence services, then more power to you. But I'd be interested to see how many of us would put our hands up and say we do that or we work there. But a national approach would be a fabulous one. If you are attending the session live and you would have a question for Joan, just type it into the Q&A panel and hit send, and that will come through to her. Joan, may I ask, could we explore the issue of blame? You alluded to that there may be a bit of a blame mentality, as in blaming the woman. How does that work? How does that equate?
Well, it's interesting that was one of the things that came up in one of the reports. So that was Simon Laperi who drew attention to that, and you do hear about it. You hear about it in the media where cases where, I forget what the woman's name, but there was a woman who was giving her baby a bottle while she was crossing the road, and there was all these shame things happening in the media. And I mean, I don't know the dangers or not of it. I'm not commenting on that side of it, but it's not the place of the media to tell people what they should and shouldn't be doing, I don't think, in that regard. There's an awful lot of shaming of women, and women feel it. So it's hard to know, really. And I don't know if he goes into exploring that in his paper. I don't think he does. It's a sort of deeper question.
But with blame, again, a woman who does present because her injuries are such that she needs to go to an emergency department. A lot of the time says, oh, look, it was basically my fault. I shouldn't, I knew if I said that, he would have got angry, or, it was my fault. I should have just shut up. He was watching this show and I know he likes it. That women themselves blame their own actions as to why another human being would, physically abuse them.
It's interesting, this notion of blame as well, because I don't know about you, Sue, or other people who've been involved with listening to the webinar, but I don't know, in the 80s, I guess, or the 70s, there were quite a lot of, what's it called now? It's assertiveness training. And I met someone the other day who still does assertiveness training. I said, I didn't know it was still around. But have you heard about that, Sue, assertiveness training?
It is. I think it may be rebranded within our systems as conflict resolution, but assertiveness training still does exist. There's a difference between, anger and or aggression and assertion, those sorts of things. But I remember when it came into its fore in the 80s.
Yeah, that's right. Well, I did 2 or 3 courses in it, so I feel like I've got the lessons down. But one of the things they emphasised in those courses was it's not a matter of blame. Blame doesn't come into it. It's a matter of communication and giving I messages. So conflict resolution really would be you can see how it would have evolved into conflict resolution. And in a way, when I talked to this woman the other day, I said, I messages, I thought sometimes like how I'm feeling or something. I feel anger when you do this. Didn't seem really appropriate in the workplace, but I think that this idea of blame and not going into blame, looking for answers, I think that's a way around this falling back on blame. Anyone blaming yourself, blaming someone else, that's not the point. The point is we've got a problem. How do we deal with it?
Yeah, yes, true. I agree. The other interesting thing, I think, from a health worker's point of view, like if a child presents and there's a query that there could be a hint of child abuse, there are mechanisms that are in place and requirements and responsibilities of the healthcare team to make sure that, reporting mechanisms are undertaken, that there's follow-up. But there is no such mechanism if the individual presenting happens to be the mother and not the child.
Interesting.
And that's, yes, which I think fits nicely with your discussion on child and maternal health as opposed to in the realm of domestic violence.
Yeah. I think now it's 21st century early years services really need to be about the family, you know.
Yep, I
and
agree.
Not just the child. Yeah.
Wendy's just identified, she just said, thank you, Joan, for a great presentation. She's an Australian nurse currently working in Fiji, which has one of the highest rates of violence against women in the world. 70 women lose consciousness every day. And Wendy's identified you've given us some great websites and resources to follow up on.
Well, I think
that's a wild statistic, Wendy. 70 women lose consciousness every day.
And in that sense, community development, you know, and again, there is talk I have come across talk about community development related in a way to respond to these issues, strengthening communities, strengthening women, empowering women to speak up for themselves, but, you know, in a safe way, knowing what the resources are, knowing where the service, knowing where to get help. And it's all time and effort on part of the nurses to get that information. But really, the department should be providing it to the nurses. You're out there in the front line.
We need to be able to go back to our workplaces and say, okay, if we're frontline and we identify the issue, then we obviously need to be able to. It's just not knowing that domestic violence exists. We need to be able to provide some substantive support for the individual. What resources are there in our community that we can refer to?
Yeah, they've got the department. They should do it. Provide it there. Be on your desk.
Yes, exactly right. So go back to your workplace and ask that question if you don't already have it. I'd be interested to know, actually. As Joan said, she's also interested. So Joan's email's on the front of the front page of this presentation, and info@Nurses for Nurses. Just hit the contact us button and I can send it through to her. But I really would be interested in knowing where you work, whether they've taken the responsibility to provide you the resources you need to make referrals and provide information to women who present, because that would add to the body of information available.
Yes, definitely.
On the subject.
And I'd be happy to send any of the articles on to anyone too if they were in touch or wanted to follow up anyway. I'm happy to follow up.
Excellent. So there we've got joan.garvan@pcug.org.au. The invitation is there. Joan's more than happy, certainly to get your information, but also to provide information back to you. Joan, thank you very much for a really interesting presentation. It's a massive subject, and today we've just touched on it. And as Wendy said, Joan, you've given us some great contacts, resources that we can go to read further and wider on the subject. Joan's also provided, as well as the list of resources, also provided 3 documents that we'll upload on the website, and they'll be available for download where you're watching the recording of this session. Joan, thank you again.
Yeah, thank you, Sue.
To everyone who's listening, I wish you an absolutely exceptional day, and I look forward to seeing you online at another webinar very soon. Goodbye.
Bye.